Hello, everyone. My name is Josh Liao. I'm a physician and faculty at the University of Washington, where I co-lead a portfolio of work of research and evaluation, studying the relationship between alternative payment models and clinical outcomes and equity. Today, I'm really excited to be sharing with you on this topic, intentions and impact of alternative payment models on equity. Before we launch in, I wanted to just note that the views I express today are mine and mine alone, and that I do receive grant funding from several groups, including the National Institute on Minority Health and Health Disparities, as well as the Agency for Healthcare Research and Quality, for projects that study payment and the relationship between payment and equity outcomes. So with that said, I really wanted to set the context for the next few minutes together, and really want to say that, something that probably many of us understand. I want to just say something that many of us understand, which is that payment is a powerful motivator in healthcare. Not the only one, but certainly a major one. I think many aspects of clinical practice and care delivery can be linked back to payment. And this includes disparities, particularly those that unfortunately face historically marginalized populations in the US. And given all these things, I think it's really important to understand payment and how it links to disparities, because doing so, I think, offers context for how we go forth and set and enact a policy, research, and practice improvement agenda. Now, the major trend in the US over the last decade with respect to payment has been a shift towards paying for value via APMs, or alternative payment models. And so kind of pulling all this together here, it drives to the point that I think it's important to understand equity in the context of APMs. And that certainly is the motivation that informs my work with colleagues here in this space. So how do we begin tackling this? I think there are a few questions we want to ask. The first, which is not the main thrust of this, but really needs to be said first, is how have major APMs impacted outcomes? It's important to think about equity, but also understand how they worked. The second is then to get to that equity question and say, how have APMs engaged or been available to historically marginalized communities? And B, within those programs or models, how have they affected disparities or gaps in outcomes among individuals from those communities? And then to the extent that we still have work to do, what are some things that we can do to advance intention and impact of APMs on equity? And I want to share 4 things that I believe can help us get there. So beginning with the end up top here, what I hope to drive through in our remaining time and leave you with is that major APMs I define as bundled payments and ACOs, just as 2 emblematic examples, have both demonstrated overall benefits based on independent analyses, but that progress in care delivery hasn't necessarily equated to progress in equity. I think there are a few reasons for that. One of that is that major APMs can exclude historically marginalized communities. The second is that there's a dearth of data, unfortunately, about how major APMs affect disparities within the program itself. And I think given those gaps and where we need to go, I think there are a few ways to improve equity through APMs. The first is to set intention and goals. And we'll get into each of these more later. The second is to incorporate equity formally into the concept of value. The third is to prioritize data and measurement. And the fourth is to think about implementation programs and evaluating those programs. So beginning with the first question here, how have major APMs impacted outcomes? I'll just touch on this very briefly and say that when we think about bundle payments and what they are, which is kind of a bundled target price for a collection of services that fit a clinically coherent arc of care. When we think about that, when we think about the ways we can define bundle payments and think about it the way we've done it in this country, which is option A, which is hospital admission through discharge and out through 90 days of post-acute care. If you think about bundle payments, we think about ACOs, which is a different view, which takes on this idea of accountability around populations of patients. So a defined population and quality and cost accountability across phases of care. So across primary care, specialists, hospital, post-acute care, et cetera. We take that view of these 2 payment models, we have to ask, what's the evidence and data around whether they work or not? And for ACOs, this is an analysis done by colleagues and showing after 3 years in the flagship Medicare ACO program, the Medicare Shared Savings Program, that there were differential savings that were achieved by ACOs, primarily driven by physician group ACOs, with savings increasing over time. So savings appear over time as opposed to immediately in the program. Paired with that, when we look at the utilization and quality side, this analysis found differential changes in ED visits but no differential changes in other outcomes like primary care visits, ambulatory sensitive care hospitalizations, and 30-day readmissions. So overall, kind of stable to slightly improved quality with cost savings. What about on the ACO side? That's the ACO side. What about the bundle payment side? And what we see here is that bundle payments can encompass both surgical and medical episodes. In the surgical episode space, joint replacement is the most common one. And this is an analysis that colleagues and I did to look at that association. And what we found, somewhat similar to the ACO example, was that there were episode savings for hospitals that participated in bundle payments for joint replacement surgery. With respect to quality, we found it generally stable from what we could see in the claims. No differential changes between BPCI, the bundle payment, and control groups with respect to these measures you see here: readmissions, ED visits, joint replacement complications, mortality. That's on the surgical episode side. If we apply a somewhat similar approach to the medical side and look at medical conditions under bundle payments, we see, again, that there are cost savings, there are episode savings. They're driven by differential decreases in skilled nursing facility spending and, in fact, length of stay reductions at these facilities. So I know that was very quick, but I just wanted to set the table slightly and say that as an APM, bundle payments create accountability across episodes where up to date we've defined in major programs those episodes to be beginning with hospital admission and out to up to 90 days of post-acute care. And in contrast to that, ACOs as an APM define kind of accountability for populations across all phases of care. And based on the data I just touched on with you, there is evidence, I think, of benefits from independent analyses that both ACOs and bundle payments can yield benefits in the form of some cost savings with stable to slightly improved quality. So these things can work is really the takeaway. And then leading from that, the question is, how have then these major models engaged historically marginalized communities? So this is an analysis done by colleagues at Penn where they looked at geographic differences in how different physicians participated in ACOs. And the idea was to say that if participation and uptake are different, then any benefits of ACOs, any care improvements that they may yield may not then be physically accessible, available to certain populations or communities. And one of the takeaways here, which I'll read from the analysis, is that physicians practicing in areas where a higher percentage of the population was Black, living in poverty, uninsured, or disabled, or had less than a high school education, had lower rates of ACO participation than physicians practicing in other areas. And I think just speaks to this idea that when we think about participation and uptake of these models, this analysis suggests that early on in the ACO era, that was not even. Colleagues and I did something somewhat similar looking at bundle payments. We looked here at a mandatory joint replacement bundle payment. We looked at what we call Medicare and Medicaid dual eligible patients, those who may be vulnerable to certain social drivers of health. And we looked at the community or the market level, and we asked the question, has engagement or participation in this program been even across communities based on the proportion of dual eligibles that they have? And what you see here is that the answer is no, is that when you look at communities and you stratify them by the extent of dual eligible individuals that reside there, what you see is that as the proportion of individuals that are duals in a community goes up, the likelihood of participation in CGR goes down. Another way of saying it was that markets that were more likely to have a higher burden of adverse outcomes through social risk factors were less likely to be selected for this mandatory program. So there was a voluntary ACO program we just saw a little bit of evidence from. This is a mandatory surgical bundle payment program. Another analysis that was recently published by colleagues and myself looked at this question, comparing a few differences to what you just saw. One is that it looked at not just the mandatory CGR program, but a large voluntary bundle payment program called BPCI. And it also looked, in addition to socioeconomic measures, it also looked at race and ethnicity, looked at Black and Hispanic individuals as well. But a similar concept of was uptake and participation and inclusion in these programs similar across communities based on the makeup of the communities. And what this thing shows, again, is the answer is no. And I won't go through each of these lines one by one, but just to say that as you move across quartiles, so as the proportion of either racial minorities or ethnic minorities increases, or as the proportion of individuals facing socioeconomic barriers increases, you see the probability of being included in BPCI, that's the first column, or being included in CJR, or going head to head, being a CJR versus a BPCI community, they differ. And it highlights again that before we can ask the question about how did certain groups do in these APMs, we have to ask the question, are these APMs available to them via provider participation? So the takeaway here is that certain models can exclude historically marginalized communities. All right, moving to that second part though, within the models that do exist, within the patients that are included within them and the providers that enroll, what are the impacts on disparities? And I have to say here that in my kind of assessment, there is far less data here than we should have, and I hope there will be more. Colleagues and I have tried to contribute to this slightly by beginning to look at our data. And so this is the study that I showed you briefly just a few slides before, where we looked at the relationship between participation in medical episode bundles and episode outcomes. And we talked about how overall there were episode savings driven by decreases in SNF savings, decreases in SNF utilization, and stable quality. So that's the overall effect. What if we look at it by particular subgroups that we're interested in? So in this analysis, what we did, we said of the patients in this assessment, we wanted to look at those that would be potentially deemed as higher clinical risk: advanced age, higher clinical severity, frail, the disabled, and prior utilization of SNF or IRF. And the idea here was that if the overall effect is episode savings driven by less SNF utilization, we wanted to understand whether A, these groups were excluded from those effects, or B, if those things were done indiscriminately to these groups when perhaps they shouldn't be. And so we looked at the main outcome, which is the SNF length of stay. And here what you see is that that the effects were variable, right? So that BPCI, this bundle payment program, was associated with differentially less length of stay for those in advanced age and frail and prior IRF and SNF utilization, but not necessarily those for high case mix. And that actually individuals with disability were actually had differentially greater lengths of stay. So we don't see exclusion from this care change process. And we also don't see kind of indiscriminate use in one direction or the other. We looked at a counterbalancing measure. We thought if SNF length of stay is differentially lower, that might not necessarily be desirable for certain groups if that leads to differentially greater bounce backs or readmissions. So we looked at 90-day readmissions across these groups. And what you can see here is that we saw no differential changes based on the point estimates and the 95% confidence intervals. If anything, actually, the point estimates suggest differentially lower or differentially greater reductions in readmissions. But again, we did not see evidence that any decreases in SNF length of stay were then related or accompanied by differentially greater readmissions, which is reassuring to us in a way. What about other measures appropriate to rehab services and post-acute care? What we saw here is that in terms of hospital discharge to institutional post-acute care, so SNFs or IRFs, that overall for most groups, it was no differential changes, but there were some observed for individuals with frailty. What about discharge with home health? Here, again, if you look at the point estimates and the confidence intervals, no differential changes from a statistical significance perspective that we observed. And so some of the takeaways from this, I think, are that you look at a program like bundle payments for medical episodes, and you see reductions in spending driven by less SNF utilization, particularly less SNF length of stay. And what we see here when we look at these different outcomes is that there is neither indiscriminate use or application of those care process or those changes to these high-risk groups, but there's also no exclusion. It's not that these groups were not did not receive any of the care changes that may have led to that. So that's what this evidence seems to suggest. And the summary here, I'll say, is that I showed you one analysis here. My group and I are currently working on additional analyses looking at race and other measures. But overall, to date, in published literature, very sparse data about how disparities between groups change under value-based payment models. I think, it's important to look at these because overall outcomes or outcomes within one group may not provide insight about disparities. So you can imagine a scenario in which you found that overall there was no effect, but when you look down at subgroups, that there's actually improvements for some, worsening for others. And so those net out to be an overall effect. You would want to know that with an eye towards equity. Two, that there is maybe a positive effect that you see overall, but that when you then look down one level, it's very positive for certain groups and just slightly for others. So that the gap or the disparities between the two groups is actually widening. And I think we have to grapple with whether we're okay with that or not. So very quickly here, I want to just touch on, given the state of the data and what we've seen and potential reasons for concern or assurance, what are 4 ways that we can continue forward to advance intention and impact of APMs on equity? My colleagues and I have tried to do a lot of work to raise awareness and engage the community around this. We've identified 4 things that I mentioned earlier. 1 is intention and goals. 2 is to incorporate equity into the concept of value. 3rd is data measurement. And 4th is implementation and evaluation. What we mean by intention and goals is that intention, in my view, always precedes implementation, whether we say it explicitly or not. And unfortunately, far too often, inequity is framed as an unintended consequence, an unintended thing that we have to monitor for. But I actually would submit to everyone that equity can be an explicit intention in healthcare payment and should be, and that we can set that intention and externalize that intention through bold longitudinal goals, in particular around measures of how we want to see reductions or eradication in inequity over time. So really just being thoughtful about how we can explicitly set an intention to reduce disparities and then goals that can chart our progress towards that is important. What about incorporation of equity into value? Here you see the value equation where quality is relative to costs. And I just want to highlight that how we define a problem affects how we go to solve it. And so long as we think about value as purely a cost and quality issue, equity or inequity will be, again, something to monitor as an unintended consequence. But I really would encourage all of us in our spheres of influence to be thinking about how do we reframe value as something that puts equity in the front and center. And I would say via this equation, as well-intentioned as it is, it hasn't done that, and we have a chance to do so. The 3rd thing, data measurement. This old adage that we can't change what we don't measure. And I would just say here that we want to emphasize in data measurement, not just how big the changes are, how big the quality gains, how large the cost reductions, but how equitable those are. Because I don't think we can be comfortable with quality gains or cost reductions that are beneficial if they come at the cost of certain groups or communities. And suffice to say, I think infrastructure and measurement strategy are critical parts of this and actually extend the earlier point about intentions and goals. Last point here, implementation and evaluation. I would say that principles are important foundation for all this work, but that we need to actually put data into the world. We need to implement real world pilots and ultimately programs. And unfortunately, despite decades of evidence about health inequity, there's been remarkably little work done evaluating how APMs and value-based payment affect equity as an outcome or even implement programs to address that. So this team you see here has worked with me, and I owe them a great debt of gratitude for the work that we've done together to begin doing this. I hope to be doing more going forward. And I'll end here by saying again that with respect to the takeaways, that what we talked about today was that major APMs, exemplified by bundle payments and ACOs, have both demonstrated benefits, but that this progress in care delivery outcomes hasn't necessarily equated to progress in equity. One reason, as we touched on, was that there's variable participation and therefore potential exclusion of historically marginalized communities from these programs to begin with. There's a dearth of data about how those APMs actually affect disparities, and that 4 things that I'm showing you here can help us really get towards the next steps of using APMs and in intention and impact to improve equity. So with that, I'll end, and I appreciate your attention.